Hey guys, wanted to discuss with you a little bit more about respiratory issues. More importantly, kind of signs and symptoms that we uh, we can fall back on in our book, as well as the different guidelines from AHA to help us better understand. And then I wanted to touch base on those 5 patients we had in week 5 assignment. So it's really important that we can understand the difference between respiratory distress versus respiratory failure, because respiratory distress, we're going to apply oxygen or do what we can um, so they don't reach respiratory failure. But when they're showing signs and symptoms of respiratory failure, then we need to step up our game. So, in terms of guidelines or the standard that you're going to refer to back in your book, anybody that speaks one word sentences, anybody that appears cyanotic, um, anybody that's hypoxic, or anybody that has an altered mental status, we would consider to be in respiratory failure. Now, of course, these also have to be symptomatic with another respiratory issue. So if we run in and have a diabetic that's altered, we're not really looking at their respiratory drive at that point. So, you get called to a respiratory issue and you see your patient is hypoxic or he's altered or he's very cyanotic or positioning, being tripod position with one word sentences, we obviously should consider him to have respiratory failure. Now, respiratory distress could be somebody that's breathing 40 times a minute, was involved in an accident, but they don't have altered mental status and they're not cyanotic. So we would, even though their respirations are outside the norm, we can still categorize them in respiratory distress. I know that you guys did really, really well on the 5 patients, but I wanted to make some clarification. So first off of that, patient number 1 was semi-conscious. I'm reading it here. Semi-conscious adult female patient that appears slightly blue around her lips. Her respirations are 8. So we know that her respirations aren't, anything between 8 and 24 is a major find. However, even though she's within that 8, if we look back and see that she's semi-conscious and there's blue around her lips, that to us would be an indication that she could be respiratory failure. Therefore, we're going to step up our game and we're going to provide ventilations, positive pressure ventilations through a bag valve mask. Even though her respirations are within range, she, that could be on the backside to where she was hyperventilating and now her drive and her muscles have failed her and now she's starting to slow her respirations. But that's thinking too much into the question. Back to it, I'm looking at the question. It says semi-conscious adult female, appears slightly blue around her lips. So at that point, we're going to look like respiratory failure based off of cyanosis and based off of altered mental status. Same with patient number 2. Tripod position, one word sentences, breathing 36 times a minute. Again, respiratory failure associated with that because one word sentences and he's breathing 36 times a minute. So if we do not act quickly in that aspect, then we would see him go into respiratory failure. His rate's going to decrease immensely because the muscles now are really, really tired and starting to give up. If he was speaking adequately or wasn't in tripod position, and I'm assuming, or typically involved tripod position, you're going to see axillary muscles being used. He's still breathing 36 times a minute. It'd be all right to go non-rebreathe. But since the key word there is tripod position and one word sentences, then we're going to incorporate a BVM on that guy because he's respiratory failure. Patient number 3 is COPD, and I know we all understand COPD. However, I really want to I want to come across that anytime that we see somebody in respiratory failure, even a COPD patient, we are not going to deny them oxygen. We are going to give them high flow oxygen, whether non-rebreathe or a Venturi mask. I really appreciate you guys really thinking about COPD and really understanding how can it affect. I'm hoping that we can bring down a lot much more because that might be kind of my downside. I don't know exact pathophysiology of COPD. So I'm going to try to get a pulmonologist down here and discuss some of the things with this, so we can understand. But I do know that their oxygen levels is why they, their drive to breathe. Morbidity rates, mortality rates, that if we throw them on high flow oxygen, we're going to see a decrease in their response, and eventually they're going to be on ventilators for months and months and months, and 50% of the time they might die. There's a new program that's coming out, and it's on a national level. If you look back into respiratory chapter, I think it's chapter 16 or 19, you're going to see that CPAP is a huge tool that has been used on COPD patients. And CPAP kind of forces, it's continuing positive pressure, and it takes the alveoli and stretches them out even more, and it forces them open so they don't collapse on an exhalation. The alveoli collapses on exhalation, and the CPAP keeps that alveoli open, so it allows them to breathe a little bit better. I'm going to try to incorporate, get that pulmonologist down to be able to discuss CPAP with you, as well as a lot more in COPD. And that's a give or take. I totally, some people were kind of all off on those questions, and that's okay. 21 times a minute is almost within the norm. Axillary muscles, and he states he cannot breathe, would be, a really good indicator to you in your patients that they're in respiratory failure. Patient 4, an unconscious patient, gurgling sounds upon inspiration, respiratory rates 4 per minute. Everybody hit that except for the suction. Remember, you guys, gurgling sounds, fluid in their airway, we need to suction that out. So remember, anytime you hear gurgling, let's grab the suction. Snoring, respirations, upper airway, we do a simple head tilt chin lift or a jaw thrust maneuver. We open the airway up. That should clear up all the snoring. Let's go with number 5. 19-year-old patient involved in a vehicle accident with no apparent injuries. Patient is hyperventilating 30 times a minute. Definitely. I mean, if you look at no apparent injuries, hyperventilating 30 times a minute, I don't think that this individual is in respiratory failure, but I feel like this individual could be in distress. It could be because of the flight or fight response, that they've just got involved in an accident, they're freaking out. It could be underlying condition, it could be anxiety, all different sort of things. So we want to try to get that patient to go within normal range. Need a little more information on that question too. Definitely a pulse oximetry would incorporate, but you all did really, really good with that patient. The AHA guidelines, and I'm going to read this to you. Any patient that we suspect an acute coronary syndrome, chest pain, without signs of respiratory distress, hypoxia, or their SATs are above 95%, does not need oxygen. That's the new guideline for American Heart Association. Oxygen is warranted if the patient is dyspneic, having a hard time breathing. There's obvious signs of a heart issue, whether it's an irregular heartbeat, whether it's tachycardia, bradycardia, whether or not there's edema, typical chest pain indications. Then we should be able to titrate oxygen or give them supplemental oxygen. We don't want to start extremely high flow, 15 liters non-breathe. We want to try to keep them within the 94 to 99% saturation mark. But again, we're having problems breathing and there's obvious signs of heart issues, then we are going to apply oxygen to them. But if they're having chest pain but they're not in respiratory distress, they're satting above 95%, based off American Heart Association standards, doesn't require oxygen. Let's go back to respiratory failure. Anytime that somebody is altered mental status, one-word sentences with tripoding position, hypoxic, consider failure, respiratory failure. If somebody is anxious and they're breathing, let's go back to patient 5, a 19-year-old patient involved in an accident with no apparent injuries. Patient is hyperventilating at 30 times a minute, and that patient, or that question also include that patient was anxious or restless, then those are indicators that the patient is becoming hypoxic. So we might be able to throw anxiety into the mix with respiratory failure if they're displaying other signs. But remember, anxiety, restlessness, is a sign of impending hypoxia. So keep that in the back of your mind. I really want you to think, critically. Not every patient you're going to run to is the same. And I have asked questions to everybody that I could possibly ask about giving us definitive definitive marks to where we can say this patient is a non-rebreathe, this patient is a BVM when it comes to chest pain or when it comes to failure. And ultimately, all your patients are going to be the same. So you got to understand the difference between distress and failure, whether this is altered mental status, whether it's cyanosis, whether it's hypoxic, whether it's showing 30 times a minute, but is very anxious and very restless. If those patients kind of show those signs based off the book and the criteria, they would then be considered respiratory failure. So look at those. Remember those things. Again, I'll try to bring down a pulmonologist on Saturday. If you have guys any questions, you can email to me, call me, text me, do whatever. 308-637-5135, flowersn@wncc.net. Yes, and hopefully I'll touch base with you, try to do another video or something like that for you guys in the future. Thanks.